It's my very great pleasure next to introduce our next speaker. He will be presenting a very nice video to explain some of the really interesting work that he's been involved in. So Dr. Paul Sondo, he's a medical parasitologist with a focus on malaria research. Following his PhD, he undertook some career development programs, including the esteemed EDCTP TDR, Clinical Research and Development Fellowship, and also the EDCTP Career Development Fellowship. So for those that don't know, the EDCTP is the European and Developing Countries Clinical Trials Partnership, and the TDR is a WHO-affiliated special program for research and training in tropical diseases. Over the last 5 years, Paul has been working on projects such as assessing the efficacy of antimalarial drugs and also investigating the genetic diversity of P. falciparum and its mechanism of resistance to various drugs. More recently, his work is focused on SMC through the implementation of two quite big projects, which included SMC NUT and SMC RST. And he's also been awarded the Institut Young Investigator Awards in 2018. A very warm welcome to Dr. Sondo.
Bonjour, je suis Paul Sondo de l'Institut de Recherche en Sciences de la Santé.
Good morning. I work at the Health Research Center in Burkina Faso. I will be presenting the research of the National Plan Against Malaria and the Ministry of Health Nutrition Department study, which focuses on the evaluation of a combined strategy of SMC with plumpidose and vitamin A zinc supplementation for the prevention of malaria in Burkina Faso. To d'abord, I'd like to remind you that malaria is a major public health issue. Prevention of malaria is a key component of the disease control strategies, and the means to prevent it are mainly focusing on long-acting impregnated mosquito nets, IRSS, preventive treatment in pregnant women, and SMC, which is an intervention which aims at reducing the prevalence of malaria in children aged 3 to 59 months. This map shows the distribution of seasonal malaria in Africa. Most of the cases are found during the rainy season. In Burkina Faso, it's between July and November. So Burkina is an ideal setting to introduce SMC. This type of prevention measure involves a combination therapy given to children aged 3 to 59 months every month for 4 months, and or up to 5 months, depending on the rain levels. And between June, August, September, and October, we have SMS implemented. It helps to reduce the incidence of malaria by some 75%, which, in spite of this strategy implemented in Burkina Faso since 2014, we still have a high burden due to malaria in children under 5. So we wondered whether there were some factors that had a negative impact on this intervention. And when you consider malnutrition, as you know, it is a major cause of child morbidity and mortality. because it weakens the immune systems and results in more severe forms of malaria in the general population, and also decrease the efficacy of the anti-malarial treatment. Even more than that, all the micronutrients deficiencies, when they are treated, are known to reduce the morbidity and mortality. So based on this, we have come up with an assumption which would be combining SMC plus micronutrient to help better reduce the burden of malaria and malnutrition in these children. And for that purpose, we have set as a primary objective evaluating whether SMC plus vitamin A plus zinc, that is, and also plus plankton and vitamin A would be more efficient to reduce the incidence of malaria while improving the health status of children, as opposed to the standard SMC. The secondary objective is to assess the impact of this strategy aimed at reducing the impact on children. Our methodology is the following. We have 3 arms. It's a randomized study which was carried out between July 2019 and June 2020 in the Nanoro health district. In the first arm, plumpy dose was combined with SMC. The second arm is the control arm with no supplementation. And the third arm is the arm where zinc was added. There was a 12-month follow-up, 6 months of active monitoring, and 6 months of passive monitoring. And over 4 months, the plumpy dose was given. Plumpy dose is a ready-to-use therapeutic food which can be directly used at home without requiring any specific preparation. 1 pouch a day per child was given for 4 months during the SMC. And for zinc, each child was given 1 zinc tablet containing 10 milligrams of zinc 6 days per week for 4 months. That is the whole SMC period. So these are the results and our findings. In total, 1,059 children had been randomized with 3 arms, 353 children per arm. At the end of the follow-up period, we have had more than 97% of children in the plumpy dose arm, 95% of children in the control arm, and 96% of children in the third arm, that is zinc supplementation, which is quite an acceptable follow-up rate, which shows that the monitoring system did work rather well. Most of the children were sleeping under long-lasting and long-acting impregnated mosquito nets. That's 91% of them, which when the SMC started, the positive rate to RDTs was 22%, and microscope studies showed 10% positive rate. Malnutrition prevalence was very high in these children at the beginning of the SMC. Stunting was also high, and there was also a low weight that is reflecting acute malnutrition. And the prevalence of malaria is already very high before starting the SMC campaign, suggesting a need for an early starting of SMC in the area. And also, when you consider the prevalence of malnutrition, most of children were under malnourished during this period. So there is a need to promote a synergy type of intervention to control both malaria and malnutrition during this season in this area of sub-Saharan Africa. The impact of this intervention is shown here. We can see the impact of the supplement given on the incidence of morbidity for all causes and the reduction of severe malaria. The green line is the control, the red one is a zinc group, and the blue line is that of children who were given the clumpy dose. The first graph shows the morbidity for all causes throughout the follow-up period. Morbidity went down in those children who were given these nutrition complement. The graph in the middle shows the simple form of malaria incidence throughout the SMC period. And here again, those children who were given the supplement had fewer cases than in the control arm. Now, when it comes to severe malaria, those children who were given clumpy dose in addition to the SMC have shown a significant reduction of severe malaria versus those who were given zinc or those of the control arm, control group. Now, we may conclude from these results that throughout the peak of the malaria season, many children with SMC treatment are also having malnutrition. Now, the feasibility of a strategy combining SMC plus micronutrient supplementation in sub-Saharan Africa is possible. This micronutrient would help further the impact of SMC to reduce further the morbidity related to malaria while improving the nutritional status of children. And this was even better when using our UTF, such as plumpy dose. I would like to thank all those who've helped us and worked in this study. I'd like to thank our partner, EDCTP, which has helped us to fund 100% of this study with the Caritative Fellowship Program. I also would like to thank the National Program to Control Malaria and the Nutrition Department of the Ministry of Health, and also Nutriset for providing the clumpy dose for this study. And I would like to thank the local community and all those who've taken part in the study. And I'd like to thank the staff of this health area, and a great thank to Nanoro and the community health worker of Sao and Zoid for all their support. Thank you also to MSF for having given me the opportunity to present the result of this study along with the scientific community. Thank you to all of you for your attention. Thank you very much.